first few lectures that I do, there's going to be a vocabulary up front that you're going to need to make sure that you understand by the time we get through talking, or at least before you come to your test. The ones today are probably the most important words you're going to need to learn while you're here. And they help you, if you understand what the prefixes and the suffixes are and the root words, then you can pretty much figure out what any word means, right? Rather than having to memorize a list of 200 words, if you kind of know the prefixes and suffixes, you'll be able to figure them out. Y'all have any questions about any of those? Some of you probably already know. This last one that you see down here, osis, all that really means, if you look it up in a dictionary, is an abnormal condition. But when we're talking about blood counts, if it has osis, that usually means it's elevated. Penia means low. Like leukopenia would be a low white blood cell count. Leukocytosis would be high. So we refer, in healthcare, we have made it mean high, although by the book it just means the condition of. Can y'all see that screen okay? Or is it the bright light on it too much? Okay. And then these are some root words. So, you take a root word, you put a prefix or a suffix to it, and then you have a word. And so you might want to practice that, like, I don't know, cell, site means cell, thrombo, so like thrombocytopenia. So thrombo, meaning a clotting cell, penia, a low thrombocyte count. And then some words. So y'all know what hemoglobin and hematocrit are, right? What's hemoglobin? It's the number of it's the amount of hemoglobin in your red blood cells. And then hematocrit is the percentage of your blood that is red blood cells. So that's the one where they draw your blood and they put it in a tube and then they spin it and see what percentage of that volume in that cylinder is red blood cells. And then petechia, y'all know what a hickey is? A hickey's petechia. It's like that blood that's kind of up at the surface of the skin. That's petechia. Ecchymosis is a bruise. Do y'all know what erythropoiesis means? It's the formation of blood. And then anything that's got megaly on the end of it means it's big. So big spleen, big lymph. I added this in just so that as we start talking about these different cancers, leukemias and whatnot that we're going to talk about today, and anemias, you get an idea for how long these cells actually live. It helps you understand how fast and how hard your body is working. So you see up there, the white blood cells don't live very long. They don't even live a whole day, 6-8 hours, something like that. And so if you think about it, and not tough, there will be the opportunity for you to write down what a normal white blood cell count is coming up. But if their white blood cell count is 10,000, and that's a normal value, and you think that your bone marrow has to make 10,000 3 times a day, right? That's a pretty active state of your body. Red blood cells live a couple months, and then platelets last about a week or so. So, we're going to do the genetic piece in a little bit, but ultimately, your DNA carries all the directions and all the material to make everything in your body, every cell in your body that determines everything about you. And typically, if there's going to be a mutation or a problem with your DNA, it's going to happen when that ladder splits. And when the ladder splits, if maybe the rungs don't split, the rungs of the ladder don't split down the middle, or a piece of the rung falls off, if it doesn't get repaired, then a disease state occurs. And so that's what happens with all these blood cancers and lymphomas that we're going to talk about today. That's what has happened. There's been some miscoding of the DNA. We all of us, as we sit here, if we were to draw our blood right now and look at every piece of our DNA, we've got some that are split incorrectly. But we have our immune system that helps repair that for us and get rid of those. So we're going to start talking about two different blood and lymphoid disorders. So if it is a lymphoid disease, it means it's either a red blood cell, a white blood cell, or a platelet that's gone awry. Red blood cell, white blood cell, platelet. Could be a natural killer cell. It is anything other than T cells and B cells. So when we think about what's in your bloodstream, you have T cells and B cells, they make lymphocytes, and then you have your red blood cells, white blood cells, and platelets. This is a nice picture that shows you the cell lines. If you're more of a visual learner, you can see which cells come from which type. But all of our stem cells originate in our bone marrow. And so those that stay in the bone marrow become B cells in that lymphoid system. If they move outside the bone marrow, then they become T cells. And then the myeloid cells they mature in the bone marrow and get released. Okay, so if you have a myeloid neoplasm, that means that one of those cells in that myeloid stem cell line has gone bad. Something's wrong with it. It can happen, again, typically it's going to happen because of the miscoding of the DNA. And so when you have this, any of these leukemias or lymphomas that we're going to talk about, they, the cell that is abnormal is going to just grow out of control. It's going to overproduce. It's not going to function well, right? Because it's missing some information. It's got some distorted information in it, so it's not going to function well. It's going to grow out of control. And then, do you remember the word apoptosis from last week? They don't die off like they should. And so when that happens, and this is true for all of these blood cancers that we're going to talk about, so it's an important process to understand. So when that happens, my body is going to dedicate the nutrients, the oxygen, the fluid that I take in to making these abnormal cells because they've got to make so many of them. And by doing that, then the other cells that should be developing are going to be deprived. And so you're going to end up, even if it's a leukemia, we all know that's going to be a problem with the white blood cell. So you think, well, why would they bleed? Why would they have anemia? And that's the reason, is because all the nutrients are being used to make this abnormal cancer cell, and that cell doesn't function. It functions, but it doesn't function well the way that it should. So chronic myeloid leukemias are most common in people that are about 50 years old. It's more common in males than in females. Ionizing radiation is a risk factor. So when y'all are studying these, try to learn what cell type is it that's going to be abnormal. And this is a group, again, it's a group of leukemias. So there might be 25 chronic myeloid leukemias. Well, what I've done is I've grouped the characteristics into these 4 groups that you will learn. But you want to know what's the cell line that's abnormal, what age group does it occur in, what causes it, because the signs and symptoms are all going to look the same. Well, there's some differences, and I'll help you see those differences. So with chronic myeloid leukemias, chromosomes 9 and 22 get busted up, and then they reconnect, and they form this thing called a Philadelphia chromosome. So if you see Philadelphia chromosome on the test, you know it's a chronic myeloid leukemia, CML. So then let's talk about what does a person look like that has this condition. So we're going to spend some time, probably more than you want to, talking about why each one of these conditions occur, and that's what you need to be writing down. And then next time it shows up in the next leukemia, and the next leukemia, and the lymphoma, we don't have to explain it over and over and over again. Does that make sense? So the other thing about these signs and symptoms, I would pay attention to if you see one that's a lot different than the others, or knowing that knowing what happens, does it make sense that a person would have this with that particular cancer? So an increased granulocyte count. That is by definition what chronic myeloid leukemia is. There's some abnormal granulocyte, could be any of the granulocytes, and they grow out of control, and they don't die off and they don't function, and then they keep the bone marrow from making all the other stuff that it should. Fatigue. Why do you think they have fatigue? I think Dr. Swansea talked to y'all a little bit about this last week in the cancer lecture. Why do you think somebody who's making, so a normal white blood cell count is 4 to 11,000 cells per cubic millimeter of blood. 4 to 11, or you'll see 4,000 to 11,000. You know, 4 to 11 times 10 to the third, or 4,000 to 11,000. So my bone marrow now is making 50,000 granulocytes, where it should be making 10 3 times a day. What's happening to the rest of the stuff in my bone marrow? It's not happening. So what causes, why do we get fatigued? You know that? So it's oxygen related. If patients that have leukemia are going to have anemia, which is a low red blood cell count, and your red blood cells are what carries your oxygen. And so if you don't have enough red blood cells, then you're not going to get enough oxygen to your tissues. And that's why you're going to be short of breath, and you're going to be tired. Your muscles aren't getting the oxygen they need, the fuel they need, so it makes you very tired. Anytime you see that someone has fatigue, your first thought should be they have anemia until you've proved otherwise, right? Yeah, fatigue because you just, run a marathon is different than fatigue from anemia, but still, somebody tells me, oh, I'm so tired, I'm going to wonder if they have anemia before I wonder if they've gone and run a marathon. Weight loss. Why do people that have cancer lose weight? How much muscle do you think you're building if you're building a gazillion cells that don't function? I have a nephew who has CML. And remember I told you a normal white blood cell count is 4 to 11,000. His was 1.5 million when he got diagnosed. So you can understand the amount of nutrients and oxygen and all that it took to grow all those cells. So clearly he had lost a lot of weight. He was short of breath. He was having a lot of bone pain. Sweats. What do you think makes a person sweat? Your body's hypermetabolic, right? My old nephew cranked out that 1.5, and think about that, 1.5 million, and he was doing that, he was making that many 3 times a day. It's every 4 to 6 hours. That's a lot of work for a body, right? So it makes you have a fever, it makes you hot. Bleeding is going to happen because we don't get to make many platelets if we're spending all of our ingredients making white blood cells. Does that make sense? Is that making sense to y'all? So you're going to see when we start talking about the next kind of cancer, it's going to have all those same things again. So what I want you to know about these signs and symptoms is understand why they happen. Because if you understand why they happen, when you see a cancer type, you'll think, oh yeah, it would make sense that they would have that. It would make sense, it would make sense. And then you're not having to memorize lists that are as long as your arm for each of these cancers. And when a patient asks you, well, why am I so tired? You'll have the answer. The spleen may enlarge. Why do you think the spleen's going to get large? You might have spleen enlargement with any of these. Why do you think you might? What does the spleen do, y'all, from A and P? Right. So something's got to clean out that 1.5 million white blood cells that's being made in my nephew's body every 3 hours. And it's going to be the spleen. And then, super high white blood cell counts. I should put his up there instead of that one, because that one kind of makes that one look like a sissy, doesn't it? So typically, again, people are going to start with these at about age 40 to 50. It can convert to acute myeloid leukemia, and we're going to talk about that next. There are some good monoclonal antibody drugs out there that are available now. My nephew, he has been in a remission for probably about 10 years now. He takes a drug, and he's very health-minded. He always does what he's very healthy-minded. And so every now and again, he thinks that he's eating his diet well enough and that kind of stuff. He may have killed the cancer, and he'll come off his medicine, and then it skyrockets. rockets back up and then it comes back down. So if you have any of these leukemias, chances are you're going to be on medicine very long term. And if the medicine begins to fail for him, then he may have to have a stem cell transplant. But right now the meds are still working for him. And he's young. He is 37, and so he was diagnosed in his 20s. So acute myeloid leukemia, again, is going to be a one of those myeloid stem cells that goes crazy. It happens commonly in folks who've had chemotherapy before or that have had radiation therapy. So that these folks are not going to have that Philadelphia chromosome. It's going to be a myeloid cell, but they're not going to have the Philadelphia chromosome. And it can, the way the blood smears are going to look is going to be different depending on which phase the cells are in when the blood smear is done. And with my nephew, and so this can happen with any of these as well. You see that word blast? A blast is like a baby cell. So you can imagine that if you're making 50 times as many cells as you typically make, that you're going to have some immature cells that get out. Did Dr. Swansea show y'all that Lucy and Ethel video? Have any of y'all ever seen that before? So it showed, do y'all know who that is on the Lucy, I Love Lucy show? So Lucy and Ethel, they go to work in this candy shop, and they're standing behind a conveyor belt, and I think their job is to dip the thing in the chocolate. I think that's what it was. Or maybe it gets chocolate squirted on it, and it comes out, and they're supposed to wrap it up. That's what they're supposed to do. So they're doing just fine, and they're looking at each other, and they're smiling because they're doing a good job, and somebody hollers from behind the machine saying, "How y'all doing?" They're saying, "Doing great." So they speed it up a little bit, and things get a little bit hairy, and they keep speeding it up until you get up with these big old clumps and stuff that you can't recognize because things are going so fast that they can't get the candy right. That's the same thing that happens with these cells whenever you have cancer. Okay. So the big difference in the signs and symptoms that you're going to see between any acute and any chronic is they're going to have bone pain if it's acute. Right? So by chronic means that this happened over a long period of time and it was almost unnoticeable. Kind of like gaining 10 pounds in 10 years, you don't hardly notice it. Acute means that it's happened right away. All of a sudden, their bone marrow has started cranking out all these extra abnormal cells, and so it hurts the bone to have to do that. When you have a slow progression of change in your body, it doesn't generally create pain because the organs that are undergoing the change have time to compensate. So these folks are going to have anemia, which is going to cause what? Fatigue. Thrombocytopenia is going to cause bleeding. And they will have also lots of infections because they're not having good working white blood cells. They're going to have the white blood cell that's malignant, that's cancer, so it certainly isn't going to work well. And then the other white blood cells that might kick in and help, they're not going to be being made like they should. So this is a very large majority of folks who have adult leukemias have AML. You can see that the survival rate's not very good. And there are some monoclonal antibodies, again, that can be used to treat this with some chemotherapy. So if you have CML, if CML goes untreated, it can convert to AML. So in my nephew, when he finally went to the hospital, they were worried that he was converting to AML. He is a coach, a college football coach, and so he was living in Montana, and all of his family's down here, and he's single, and he was in his apartment, and he was having so much, because he would watch he was watching a lot of football video, and so he was having a lot of neck pain, and so he didn't really think that much of it. He was living by himself and working all day, and then coming home and reviewing films and that kind of stuff, and his neck was hurting a lot, Well, apparently it got to where his arms were starting to get numb, so then he decided he needed to go to the hospital. And so when he did, one of his vertebrae had disintegrated from the malignancy, so then they had to fly him over to a big hospital in Denver, and they had to go put a metal cage in his neck. So you can see his was very chronic, right? He had been home at Christmas time, and he and his dad had been out in the backyard throwing the football, and he was a little tired, a little sore, but didn't think anything about it. But it got to where, he got to where his arms were numb before he ever went to get checked out. It's real unusual. That's an unusual case because he's pretty young for that. And then if it's a lymphoid problem, it's got to be a cell in the lymphoid cell line. So that's either going to be a T cell, a B cell, or a natural killer cell. Now the other place in the lymphoid system that cancers can occur in the lymph nodes themselves. So if it's a lymphoidal cell and it's in the bloodstream, it's still called leukemia. But if it's in a lymph node, then it's lymphoma. That's just some nomenclature stuff. So CLL is chronic lymphocytic leukemia. It's going to look similar to the other the chronic myeloid leukemia that we talked about. Again, it's more likely to happen in males than in females. This one's really closely associated to consumption of chemicals like Agent Orange. Roundup is a big perpetrator, and I guess guys tend to work in those kinds of environments more than females do, and probably that's the reason that more men have it than women. If you have any family history of any kind of blood malignancy, then you're more likely to develop this. There's a malignant B cell precursor. So you're going to have B cells, some B cells that don't die off. You don't know this yet, but the B cell's job is to become an antibody. So if you have a lymphoidal disorder and you have a B cell problem, it means you can't make any antibodies. So you're growing all these crazy abnormal B cells, burning up all your fuel, all your energy, not making other good cells, and now on top of that, you're not making antibodies either. So the signs and symptoms, y'all, they all see how they look similar. The fatigue, the bleeding. If it's a lymphoma, you may have an enlarged lymph node. Same thing, fever, elevated white blood cell count. Anorexia means, y'all know what anorexia means, you don't feel like eating. You can have anorexia really in any of these. Weight loss and infections for all the reasons that we already talked about. Does that make sense? So the real difference here is what's causing it, and it's going to be a B cell precursor and the bone pain. So there'll be at least one question on the exam where we're going to give you some data and ask you, which of these leukemias do they have. And so the first thing I would do is see if they have bone pain or not. If they have bone pain, I can scratch the two with a C off the list, and now I got to, narrow it down between the two that have acute in them. So bone pain is a telltale that it's an acute process going on. CLL happens, do we go back to the page where when it happens? It's usually in older folks, like 60, 70, and they typically get diagnosed really just by accident. They're having some routine lab work done, and the blood counts are out of whack, and so then they start investigating why that happened. It does have a good survival rate. These cancers that grow slowly, people live longer with them. It's sometimes harder to take care of it with chemotherapy because chemotherapy tries to target cells that divide very quickly. So I guess it's a double-edged sword, right? If you got an acute cancer, you're more likely to get a cure because it's happening acutely, but if you don't, it's going to kill you quickly. And if you have a chronic cancer, you might not get a cure, but if you're not going to develop this till you're 70 and you get to live for 20 more years anyway, Then ALL is acute lymphoblastic leukemia. And again, if the lymphocytes are concentrated in a lymph node, it's going to be a lymphoma. This is the one that's super common in kids. Maybe some of you all had ALL as a kid. If not, somebody that went to your school or your church, I'm sure you know someone who had ALL. Super common in children. It has a really good survival rate in kids. It doesn't have as good a survival rate in adults. If your parents were exposed to, your mother was exposed to radiation while she was pregnant, then that's going to increase the likelihood that you have it. So here you're going to have could be a T cell or a B cell. So it's either of those cells that are in that lymphoidal system that do the same thing. They grow out of proportion in numbers and they don't die off. So it's a T cell or a B cell. Not a precursor to a B cell, but a full-on T or B cell. That phrase down there, the lymphoblasts crowd the bone marrow and suppress formation of other blood cells, that's what we've been talking about the whole time. Doesn't matter which cell it is that's growing too much and not dying off, they are crowding out the bone marrow. That's what that means. And then they're preventing the bone marrow from making all the other cells that it should be making. So these folks are going to have similar signs and symptoms. Again, they're going to have bone pain. And there's going to be an abrupt onset of this. I'm trying to look to see if there's anything here that looks really very different. Epistaxis is a nosebleed. And you see down there activity avoidance. Why do you think kids might avoid activity if they have ALL? It hurts, right? Yeah. Like a 3-year-old might not be able to tell you that my legs hurt, and you know what I mean? So they're just going to quit, trying to ride their bike or quit kicking a ball and that kind of stuff. And everything else up here looks really similar, doesn't it? Y'all know what pallor is? Paleness. And that paleness again happens because you don't have much red blood cells. So there's a relatively good survival rate for this. I have a friend who died with ALL though. She was, goodness, it's been 10 years probably now, and she had gone in to have some minor little surgery, I don't know, like a nasal septum repair or something like that. And she, when they got ready to, it was an outpatient procedure, so she came back out of the OR, and they couldn't ever get her off of her oxygen. Her oxygen levels didn't quite respond like they should, so they did some lab work on her, and lo and behold, found out that she had ALL. Well, she got a transplant. And when she got her transplant from her sister, and then her sister's cells took over and killed her. It's called a graft versus host rejection. So they lived in St. Louis, so we all went up there with a great big party because she had kicked leukemia's tail and that kind of stuff. They got back the reports that said the bone marrow had taken. She would start making the type blood that her sister had, so it was a success kind of thing. But then she started getting sick again, and that's what happened to her. She didn't live very long after that. So this might be an example of a question. 64-year-old patient who's had radiation therapy. So that makes me think, who is at risk when they've had radiation therapy a month ago? They have an elevated white blood cell count, multiple bruises, upper respiratory infection, and long bone pain. So, who do you think that is? AML, right. Because of bone pain, and then the ALL is the one that happens in kids. So have we changed that question? Is that in y'all's set of slides? Yeah, I pulled this off the internet, so it's in your slides. If I had changed that to a kid, then the answer would have been ALL. But can you see the thought process? Now, the other question we might say is the patient with whatever disease or whatever complains that they're always tired. Why are they always tired? And you'd have to be able to explain the process of why they get anemia and why that makes them tired. So another type of blood cancer is multiple myeloma. What it means by plasma cell, it means that it's not the red blood cells, the white blood cells, it's one of the cells that are in the plasma itself. The plasma is the clear part of your blood. Like if y'all seen where when blood gets spun down, there's clear looking yellowish stuff at the top and red cells at the bottom. It would be one of the cells that's up there in that clear fluid that becomes a malignant. And it's going to be a malignancy of a B cell. And remember we said B cells become antibodies. And they're going to have these antibody fragments called Bits-Jones proteins. So those are going to be your identifying factors. Bits-Jones proteins. These folks typically will have little tumors spread all around. It's common for it to be in their brain. It's common for it to be in their bones. And I've got a picture of an x-ray coming up, but you'll be able to see where the holes are in the bone from that bone cancer happening. It is not very common. It is more common again in males than females. It's more common in African Americans than in Caucasian Americans. Radiation, Agent Orange, probably Roundup. All the exposure to those things are risk factors. So insidious. Insidious means, real slow. The onset's very insidious. So again, they're not all of a sudden wake up one day and say, "Man, I'm tired." It's gonna have been gradual. And if you're 50 or 60 by the time this happens anyway, people start thinking, well, I'm older, I'm gonna get tired more often and more easily, so they don't get too concerned about it. And so a lot of times when they come in to get treatment, they're pretty far advanced. So if you notice here, the signs and symptoms look different. What looks different about these to you? All that bone stuff, right? Mm-hmm. The renal failure probably happens because the calcium plugs up the kidneys. Those long bone fractures are going to happen, or fractures, those are going to happen because the calcium is pulled out of the bone. They might have cardiac abnormalities because of potassium. And then the other things, the bone pain, the anemia, thrombocytopenia, they look the same. So certainly if we give you some indication that they're, they've recently broken a bone, or they come in with kidney stones, then that should help trigger your brain to think, oh, this is probably multiple myeloma. The students oftentimes will say, it's just the way these questions are worded, they're so hard. Whenever you read the test question, what I want you to do is read the question and don't read any of the answers. Read the question and stop and think about, what do I know about this disease, whatever it is up there in the top part of the question. And then go answer the question. Are y'all liking the math, the way the math works? And so this is how I equate this to math. With the math, it's like, find what you're looking for, write it down. Milliliters per dose equals, and you put your milliliters out. It's the same thing. If you have a process for answering these questions, it's going to help keep you focused and help you to know where you're going. So again, read the question, think about, what do I know about multiple myeloma? And if all you could call to mind about multiple myeloma is, it's the one with the bone stuff, it happens in older people, it's a cancer. Chances are, whenever you go down to look at that list, you're going to be able to pick out the right answer. But you're going to have to just stop and think about it for just a minute, because all those wrong answers, what they're called? Distractors. And Dr. Swansea are really good at writing distractors. Because there'll be all kinds of things that do happen in other cancers that just might not happen in this one. So you can't study it to be familiar, like think, okay, well, I'll recognize this on the test. I know this well enough, I'll recognize this on the test, just don't do that. Make sure that you really know it. But that would be the best way, I think, for you to take the test. And a lot of times when students will come to see me after their second or third test, we'll sit down and we'll want to look at some of the tests. So I'll cover up the answers and ask them, and sure enough, the first 2 or 3 words that come out of their mouth is exactly what we asked in the question. So if you stay calm, and if you study, and everyone, you got to study. Are y'all already studying? Do y'all already know the content from last week? Mm-hmm. Hopefully. If you've done that and you can keep yourself calm during the test and do that, you'll do just fine. Again, it happens more often in older people, and then there are treatments, chemotherapy, transplants. In Hodgkin's lymphoma, it's a lymphoma, so that means that the problem is in a lymph node, right? And Hodgkin's disease, there are categories of Hodgkin's disease as well, but I've just classed them for you into either Hodgkin's type or non-Hodgkin's type. But there's a bunch of Hodgkin's types and there's a bunch of non-Hodgkin's types. But at this level, you don't have to know that. And that's for like the oncologist who's going to prescribe the treatment to figure out, right? Because what you're going to do as a nurse, you need to know generally what happens to people who have Hodgkin's or non-Hodgkin's, and to know how to take care of them, to know how to manage them. So with Hodgkin's disease, you get a Reed-Sternberg cell. So these where you get a particular cell are particularly easy to recognize on the test, right? It happens in association with Epstein-Barr virus, and we'll talk a little bit about Epstein-Barr virus before the day is over. In Hodgkin's disease, there are several different forms of it, but the good thing about having, if you have a lymphoma for it being Hodgkin's disease, is that it metastasizes in a very known pattern. So if I have an enlarged lymph node in my groin and it turns out to be Hodgkin's disease, well, there's a map somewhere that says, you know, the next lymph node that's going to be involved is this one, and then this one, and then this one. So surgically, they can go in and take out the impacted lymph node, and then 2 or 3 in front of it. And since that's the way it spreads, then it stops it from spreading. Does that make sense? In non-Hodgkin's, it's not like that. It's real erratic. So that would be an advantage to having Hodgkin's lymphoma. It happens most commonly in young males. And then it happens once you get older as well. Some other risk factors have any kind of immunological problem. So that's true for any cancer, any of the blood cancers, any of the solid organ cancers that we're going to talk about. If your immune system is suppressed, then you're not going to recognize those abnormal cells, right, and attack them when they occur. So immunosuppression is a common cause for all of these cancers. H. pylori is a bacteria, hepatitis, and exposure to different chemicals, and there's some listed there for you. The thing that typically brings a person to see a healthcare provider when they have Hodgkin's or non-Hodgkin's disease is that pruritus. Do you know what that means? It's itching, it's crazy itching. You know, again, most commonly these are going to be young males that have it, and so they're, you know, going to be in good shape physically, their heart and lungs and kidneys, and so they're not going to start feeling the other signs and symptoms, the fatigue and the bleeding and that kind of stuff, as quickly as they're going to start to have that crazy itching. Other than that, y'all, everything kind of looks the same. That weight loss, anorexia, sweats, but you do have that swollen lymph node there. So the survival rate is pretty good if you are under 65, and it's okay if you're older than 65. And then non-Hodgkin's disease is similar. It's going to be a TSB or a natural killer cell, but you're not going to have a Reed-Sternberg cell in this one. And like I mentioned before, this one's going to spread erratically. So I might have that lymph node that, you know, that makes me notice it. It's in my groin. Well, the next one that has it might be in my armpit, or in the back of my neck, or in the other leg. So you can't get ahead of it by taking out the lymph nodes where you know it's going. And so it makes it harder to control. This is also thought to be associated with Epstein-Barr virus. Epstein-Barr virus can cause mononucleosis. That's probably where you may have heard that before. So when you look at their signs and symptoms, y'all, they look a lot alike. Anytime you have a swollen lymph node, y'all know this already, right? If it's tender, it's probably because there's some kind of injury or infection. You know, the lymph node's actively trying to drain something. If it's non-tender, and particularly if it's non-tender and just on one side, then that's the kind that you need to go have evaluated. Y'all have had a cold before, right? And both of the lymph nodes in your neck swell up and they're sore. Well, it's because it's draining all that business out of your head. But if you just randomly have a lymph node in your groin or even in your neck, if there's nothing going on and it doesn't hurt, you should go and have that evaluated. Y'all know what joint effusions are? It's like water on the knee. It's a collection of fluid in the joint. So the survival rate varies depending on how sick they are, how far into the stage of the cancer they are when they're diagnosed. Unfortunately, most people are further progressed by the time they are diagnosed, and so the farther you get. And in cancer, did Dr. Swanson, she talked about stage E cancers last week? So a low number means it's more, it's not quite as advanced. So she talked to y'all about how cells change, you know, that it changes from one cell type to another. So like in stage 1, maybe it's just a little bit changed. So there's still some cellular function there, and it's just starting to look a little abnormal. In stage 4 is you couldn't see anything about the normal cell in there. So the sooner you get that along the path, the sooner you start treating it, the better your survival rate is going to be. And then just a minute on mononucleosis, because you're going to see as we go throughout this class that there are lots of disease states that are associated with Epstein-Barr virus. So y'all all know mononucleosis is called the kissing disease. It is spread with blood and body fluid contact. Most of us have had Epstein-Barr virus or have been exposed to it and have developed some immunity to it. Once you have it in your body, it just stays there. Now, everybody who has Epstein-Barr virus is not going to end up with some type of cancer, but some folks do. So, mononucleosis, what happens is you've shared a Coke, you've kissed somebody at a party, and you've kind of forgotten about it, and now about a month later, you're starting to feel like you have the flu, starting to maybe have some swollen lymph nodes, maybe your liver and spleen swell up. That's what the signs and symptoms and how they progress with mononucleosis is. And patients will also typically, with that flu-like pharyngitis, being the sore throat. And so, when a person has mononucleosis, if their liver or spleen is enlarged, they need to not participate in any sports, because this happens a lot in preteens and teenagers. That's your category of folks who are typically, on the school soccer team, or they play baseball in the neighborhood or whatever. They need to be advised not to do any of those activities until that liver and spleen go back down. Because if you take a hit to a swollen liver or spleen, it's going to cause a lot of bleeding. And then some folks get over it really quickly, and some folks have it for a long time. So here's another potential kind of question. The patient's diagnosed with multiple myeloma and asks the nurse why they've developed a kidney stone. So we kind of already talked about that. So what's the answer there?
B.
B. Do you see how the other ones seem like they would be right? Especially C. But B is the most direct answer there. And that was just an example of how we might say, there's something wrong. Can you explain why it's wrong? So those were the blood cancers that we're going to talk about. So again, everybody learns differently, but maybe you want to make some little walk side by side and just learn all the causes and the signs and symptoms up, and the risk factors and the age groups, or maybe you make index cards, or hopefully you're taking good notes and you can just study right with those. So we're going to shift gears and we're going to talk about diseases of the blood. We'll talk about neutropenia, and then we'll stop, because I can see y'all starting to yawn a little bit. So anyway, that's how we're going to finish out this morning's part of the lecture, and then we'll get to the genetics, I guess, will be hour 3. So neutropenia means that their white blood cell count is low, and particularly the neutrophils are low. So neutrophils are a type of a white blood cell. Next week when we do immunology, we're going to look at all kinds of white blood cells, but today we're just looking at neutrophils. There are lots of things that can cause it. There are drugs that cause neutropenia. There are diseases that cause neutropenia. There are medications that cause neutropenia. Autoimmune disorders, all kinds of things can cause your white blood cell count to be lower. Vitamin deficiencies. Whenever a person's neutrophil count gets below 500, we say they're at life-threatening risk of infection. So when it gets below 500, that's when we need to start isolating this patient and protecting them from their environment so that they don't get infected. Because they don't have any white blood cells, they're going to be at higher risk for infection. And you may or may not know this yet, but infection is a super high cause of death. And so you're going to learn more so next semester than this semester that you're going to have to start. When you pick up your patient, you're going to have to go and pick your patient up from the hospital, meaning go and study them and get ready for the next day. And you're going to have to rank order everything that's wrong with them. And everybody knows airway, breathing, circulation, right? Airway, breathing, circulation. Well, right below that comes infection. Because infection is just as lethal as these others. It gives you a little more time. Airway, breathing, and circulation kills you in just a few minutes. Infection kills you in a day or 2. Okay, so neutropenic precautions means that you protect the person from the environment, basically. And you'll learn exactly what you have to do to protect them from their environment next semester. Y'all take a break. It's about 7 till, and I'll come back at 10. Please.
I think I'm gonna go buy a cup of ice.
A cup of ice.
Let's see, the big ones here. That headache is a big one. And if you think through these, well, let's talk about back pain. Why do you think somebody might have back pain? Look, back pain, paresthesias, joint discomfort, epigastric pain. Whenever tissues are deprived of oxygen, they hurt. Right? If you put a rubber band on your finger and let it pinch off the blood flow, it's going to make your fingertip hurt. So that's why the headache, that's why you have all these pain syndromes when you have polycythemia. You might think that, well, heck, they've got a whole bunch of red blood cells, why don't they have a whole lot of oxygen? Well, what's missing there is the fluid that the oxygen has to go back and forth through. So even though there's a lot of red blood cells there, the oxygen can't get to the tissues. Weakness, oxygen supply, fatigue, oxygen, pruritus. Why do you think they might get pruritus? The itching. Because all those cells have to die, right? And whatever the liver and spleen can't clear out, not the liver, the spleen can't clear out, it's going to start depositing in the skin. So it's going to make it itch. Dizziness, oxygen. Sweating, they're hypermetabolic. We're making all those red blood cells. Visual disturbances. The retina of your eye has little blood vessels on it, and the light has to be able to refract right off of your retina. And so if those blood vessels are distended and big because they're full of blood, it's going to make it harder to see. Weight loss, they're spending all their energy, they're spending all the nutrients they have in their body to make red blood cells and nothing else. You know what paresthesia means? Paresthesia is numbness, tingling, maybe burning sensations, and typically it's in the periphery, like fingers and toes get numb and tingly. The nerves aren't being oxygenated well, that's why it happens. You know what dyspnea is? Shortness of breath. You're not able to exchange good oxygen, so you constantly feel like you have to get air. Joint discomfort from the thick blood in the vessels that are supplying those joints. Stomach pain, large spleen, that should make sense. Those make sense to y'all? So, how do you treat it? Well, you can get rid of the cause, So, a person who has COPD, you can't get rid of COPD, but they may have to take some oxygen. They may have to live on oxygen. That person who lives up in the mountains can come down to sea level. Cigarette smoker, quit smoking. My brother-in-law, he doesn't have any vices. He's not a smoker or anything. And what he does is about every 2 months he goes and they draw feeding of the blood. Which is what that one is. That third one down there is phlebotomy. They just draw off blood. And then there's also chemotherapy and immunosuppression if it's needed, but it's pretty easy to just draw the extra blood off. And so then we're going to shift gears and talk a little bit about things that make you bleed. We're going to talk about these 3 different categories of things that make you bleed. So thrombocytopenia means that their platelet count, thrombo meaning clot, cells that make you clot, are low. So there's lots of drugs that can cause it. Viral infections can cause it. If you have a diseased spleen or liver, you can have that. Any number of reasons. You could have a spleen that's just trapping the platelets in it. So there's lots of reasons that you can have low platelet count. This is another list of things that can cause low platelet counts. We're going to talk about that last one down there, DIC, later. Heart valves, the reason that an artificial heart valve causes you to have a low platelet count is because if you have an artificial heart valve put in, you're going to take anticoagulant medicine for the rest of your life. So that, your body is going to think that heart valve is a foreign thing that doesn't need to be there. So the first thing that's going to happen is platelets are going to stick to it, and then it's going to plug up the valve. So people that have heart valves will take blood thinners or aspirin the rest of their life. So the signs and symptoms are going to be any word that means bleeding, basically. And all these words down here mean bleeding somewhere. We talked about petechia, purpura. Purpura are those, you notice it a lot on older people's skin, they have those collections of that really purple looking blood right up under the skin. That's what purpura is. Older people, their skin and their blood vessels are more fragile, so when they rub things, they get those really dark, what looks like a bruise there. You might bleed their head, they might bleed their head. We already said epistaxis is a nosebleed. So y'all, we might say on the test, we might pick another word, we might put ecchymoses on there, or they're vomiting blood, or you see blood in their urine. Any way a person can bleed, they're gonna bleed more if they don't have enough platelets. We might tell you that when you give them a shot, they bleed profusely, or they come back from surgery, we can't get the bleeding to stop. So try not to get hung up on just those words, but just anything that means bleeding, they can have. And that's really gonna be true of all of these bleeding disorders we're gonna talk about. So get rid of the cause if you can. And patients will get injections of vitamin K. Vitamin K is needed as part of the clotting cascade. It's processed by the liver, and you have to have bacteria in your gut for that to happen. Thrombocytosis means too many. And if you have too many platelets that are released, what's going to happen is that your body, so all of us while we're here today, we are forming little clots through our clotting cascade, and then part of that is you have fibrinolytic properties that try to break those clots down. So we all have little clots forming and the stuff that's breaking them down. Well, we run out of platelets before we run out of stuff that breaks them down. So if you have too many platelets released, your body's going to break them down, and then they're going to break them down more quickly than they can be made, and the person's going to end up hemorrhaging. So you would think that you would turn into a clog of blood if you had too many platelets, but it's probably going to go unnoticed at first, and then you're going to start having bleeding issues. Do you know what ischemia means? It means lack of oxygen in the tissue. You know what a pulmonary emboli is? A blood clot that goes to your lungs. Okay. So if you have a coagulation disorder, it's going to happen because something in that clotting cascade is either missing or it's not working right. And so you can't form a clot. So we have hemophilia A and hemophilia B, and that's exactly what happens. You can't form a fibrin clot, and the only real difference in hemophilia A and hemophilia B is the factor that's caused by. So factor A is caused by 8. Please remember A and 8, and B is 9, factor 9. So if you're missing some of this on your clotting cascade, you're not going to be able to form a fibrin clot. And hemophilia A is the most common. Hemophilia occurs more in males than females as well. Who knows why? So when you look at all these signs and symptoms, y'all, they all mean bleeding. Now I might ask you on the test what hemarthrosis means. So the words that you don't know, you need to look them up. But I'm going to tell you what they are right now. So y'all know what a hematoma is? A hematoma is a collection of blood somewhere it shouldn't be. Hemarthrosis, what do you think that might mean? Heme and osis means, condition of, you got blood somewhere. Where is it?
In your joints.
Yeah, right, because y'all all seen a football game where somebody had to have an arthroscopic procedure on their knee because they got hurt. So referring to joints. Hematuria, where do you think that blood is?
Blood
In the urine. That's why learning those roots and prefixes and stuff is so helpful, because you know what I mean. It's like you don't have to learn every other word in the medical language. GI bleeding, intracranial hemorrhage. How does a person get diagnosed with hemorrhage? Yes.
Can you look like the hematopietic?
That's bleeding into the joints.
Okay, good.
So the way a person gets diagnosed with hemophilia is, chances are a parent's going to bring their child in and say, little Johnny just, he bruises so easily. And when he brushes his teeth, his gums bleed, and the parent's going to be describing all these incidences of bleeding that they don't think is normal. And so based on that, the provider's gonna say, okay, well, we're gonna draw some blood, and they're gonna do a factor analysis of the clotting cascade and just find out if there's anything missing there. And then that's how it's diagnosed based on which one's missing. And to fix it, then they're gonna get replacement therapy. For whatever it is they're missing, they'll get that to help them clot. And then again, children that have hemophilia probably shouldn't be playing contact sports, right? Because that's not a good thing to do, to be getting hit, you know, somebody tackling you or whatever, if you're gonna have a tendency to bleed. And then von Willebrand disease is very much like the hemophilias, except this is, you're missing something that's used to make factor VIII. But the end result is from all of these is you're not going to form a fibrin clot. So you have A is 8, B is 9, and von Willebrand is a precursor to, or it's a protein carrier for 8. And so here again are a bunch of words that mean bleeding. So, menorrhagia, y'all, that means really heavy menstrual bleeding. Now, could I ask you, could I say menorrhagia and be talking about, you think hemophilia A or B? I could, they all mean bleeding. So the real difference between these bleeding disorders, first of all, you need to know every word of it that's shown up in these lectures that can mean bleeding. And then the difference in which factor causes it. That's all, that's all there really is to know. So they're gonna be diagnosed much the same way. You know, kids bleeding more, have bruising more. They're gonna draw some blood and figure out what's missing and then try and replace that. What, do y'all remember studying vitamin K and in the liver and A and P? Can y'all tell me how that works? So vitamin K is processed, formed in the liver, but for that to happen, you have to have bacteria in your gut, and you have to have a mature liver. I don't know how many of y'all, have children yourself, or maybe you went and visited somebody right after they had a baby, and they got the curtain open in the nursery, and you see them give the baby a shot. That's what they're giving them is vitamin K, because the baby's gut is sterile, there's no bacteria in it. And so their little liver is not mature enough to process the vitamin K, and it can't even be processed yet because there's no bacteria to make it. So you have to have a functioning liver, and you have to have a contaminated gut to make vitamin K, I guess is the long story there. The short story, I mean. Here's a bunch of words that mean bleeding again. Melena, what's melena? Blood in your stool. We already talked about hematuria, we've already talked about menorrhagia. People who have, who take blood thinners every day for whatever reason, whatever disorder they have, if they end up in a car accident and they have to have an emergent surgery, they're gonna stop their blood thinner and they're gonna give them some vitamin K before they take them to the OR. That's how well vitamin K works to help you coagulate. So again, any of these bleeding words could really go anywhere. They really could go with any of the leukemias as well, right? Because the people who have all those leukemias are not making very good platelets either. DIC, I like to talk about this disease. What happens in DIC is that your patients, number one, are going to bleed to death. They're not going to turn into that clump of jello like I mentioned before. Something happens that sets this process in place where they're going to start having all these microvascular clots, lots of blood clots forming in their blood vessel space. And so their body's going to start breaking them down, and then they're going to run out of the things to break those clots down before they're going to run out of platelets before they run out of stuff that breaks them down. So the people that get DIC are people who have had some kind of big stressor to their bodies. So I was a burn nurse. It was very common that our patients who had big burn injuries would develop DIC. It's very common for women who have really bad deliveries. A lot of hemorrhage, a lot of complications of delivering their babies. It's common that they'll develop DIC. It's common people who have had big car accidents or a big surgery or a big cancer. So, any huge insult to the body can set this off. It's idiopathic, we don't really know why it happens, we just know that it happens, and then we know to look for it, and we know what the signs and symptoms look like so that we can hopefully get it taken care of if it does happen. So there's a bunch of things listed there for you that could cause, that it follows. So again, you're gonna have this trigger, whatever it is, it might have been that big burn injury, then you're gonna increase your clotting, you're gonna consume your platelets, and your clotting factors before you do the fibrinolytic properties, and you're gonna start to bleed. People, bleed everywhere when they have DIC. So these are a whole bunch of, bleeding words again. The one that's on there, I think we haven't talked about yet, is the next to the last one down there, which is hemoptysis. Does anybody want to take a guess what that is? You can't guess it by the way the word looks, except to know there's blood is coughing up, spewed up blood. That's gotta come from a Greek word or a Latin word. That's coughing up blood. Which word? The second to the bottom, hemoptysis. The other ones we kind of defined are, orifice bleeding, any hole in your body blood can come out. People will ooze blood out of their ears and their eyes and nose.
What does the first one mean?
Petechia is like a hickey. It's that little
Okay.
blood that you can tell it's been pulled up to the surface of the skin.
Thank you.
I mean, you don't get petechia from a sucking motion, but that's what it looks like. It looks like what a hickey looks like. And so the way it gets diagnosed is, number one, people who are working in these areas that take care of patients like this are always vigilant for it to happen. So there's gonna be some kind of history, some big event that's happened to this person, and then people are gonna start to notice that they're starting to bleed a little bit longer than they should, maybe with a needle stick, or maybe a little bit of blood in their urine. Maybe their blood counts are just falling off a little bit. We don't really even see any bleeding, but we know they're losing blood somewhere. So it can be like that. Patients can stay on the floor and do just fine, or it could be like, it could kill them. So it happens, on a long range of severity. And so the ideal thing to do is, if you recognize it early, is to give your patient a big old dose of heparin, which seems counterintuitive, but the idea behind giving that whopping dose of heparin is that your body stops releasing those fibrinolytic factors. And so it hopefully stops it. It doesn't always stop it. And if it gets, if it turns out to be a major case, these folks are going to be getting blood transfusions and clotting factor transfusions and fresh frozen plasma. We're just going to be giving them all the blood products that we can, and then trying to keep them alive long enough to, fix it, to let the body fix it. We can't really fix it. If there's a reason that we can remove, then we'll remove it. That's kind of hard to do, but say you've got a great big infection, we'll get you some antibiotics, and hopefully the antibiotics will keep you alive long enough for the antibiotics to kill the infection. But usually it's a matter of keeping them alive and replacing those clotting factors until they can, their body can correct it themselves. So look, we got 30-something slides to talk about, and all the rest of them are anemia. So that should be a clue that on the test you're going to see some anemia questions, So we know what anemia is. It means that you are deficient in red blood cells. There's all kinds of different anemias that can occur, and we've already said the big telltale sign about anemia is going to be fatigue. So when you have anemia, you're not going to have good oxygen carrying capacity. So you're going to see widespread implications of anemia. So what happens, the very first thing that happens if a person's blood count goes down is the heart's going to beat faster. And your respiratory rate's going to be faster because your brain's thinking, oh, her toes aren't getting enough oxygen. I'm going to have to beat faster to send more blood down there. And you're going to have to breathe more to get more oxygen in. So I say that to say, along with that, anemia equals fatigue. Y'all need to, anytime you see a patient has an elevated heart rate, you need to think, oh goodness, they don't have enough blood, until you find out otherwise. Right? Because a person, we already said, airway, breathing, circulation. Airway, breathing is the third one down, circulation. So people can die from, loss of blood in a short period of time. And that's another thing. Whenever we give you questions, and that's true in our class, it'll be true in other classes that you have, we're not going to give you information that you don't need. Like, we're not going to tell you what a person's heart rate is unless we want you to make some kind of decision, right? We're not going to say the patient's heart rate's 120 and keep it a secret from you that they just rode their bicycle up a mountain, right? So if we tell you it's 120, it's 120. And unless we explain why it's 120 in the question, it's not supposed to be. That's a bad finding. Does that make sense? Okay. So you're going to have increased heart rate, increased respiratory rate. If it goes on for a long, long time, that left ventricle will get bigger, and you might have bone pain and that kind of stuff. But typically, anemia gets diagnosed and taken care of before it gets that far. So people like to classify anemias by bunches of different ways, and one way is the way the size of the cell, the way it looks, that's what morphology means, what does it look like, and by the color. So those little prefixes over there, normo, macro, micro. So normo means, what do you think? Normocytic, normal cell size. Macrocytic would mean the cell is big. Okay, what about hypochromic? It means that there's not much color in the red blood cell. That's probably going to be an iron deficiency anemia. Not good color. So good again with the prefixes and suffixes. So we're going to talk about these different kinds of anemias now that are listed here for you. The first one we're going to talk about is blood loss anemia. So blood loss anemia is pretty easy to identify, right? You've lost blood. And you can either lose blood acutely because you just cut your leg, or you can lose it chronically because maybe you've got a hemorrhoid that bleeds a lot, or some other condition that would have you oozing blood over the long haul. So if it happens acutely, you would expect that their red blood cells would be the normal size, shape, and color, right? There's just not many of them. If it happens chronically, well, now you're going to start having small cells that don't have much color, because whenever your red blood cells die, the iron that's in them gets recycled into the next red blood cell that gets made. So if you're losing blood, you're running out of iron, and so that's going to mean your cells are not going to have what they need to develop. So they're going to be small, and they're going to be light in color. Up there, we all need to go back and talk to you about delusional again.
Yes, please.
Delusional means that, I'm trying to remember what we said earlier, but delusional means that for some reason you've got more water in your bloodstream than you need to have, and so it looks like your red blood cell count is low, but it's really because you've got more water in your blood than you should. That's what delusional means. So hemolytic anemias. These are, I'm trying not to get ahead of myself. These are diseases of hemoglobin. That's what hemoglobinopathy means. There's something wrong with your hemoglobin. It can be caused by a blood transfusion reaction. There can be some genetic issues that we're going to talk about, like, for example, sickle cell anemia is a hemolytic anemia. And then there's lots of drugs that can cause your blood to lyse. Lyse means split open. Hemolytic cell gets busted open and it dies. So there's a long list of drugs there for you. So when this happens, the red blood cells bust open and they die. And so you're going to have a bunch of cell fragments, and you're going to, your spleen's probably going to be enlarged, and you're going to have all the signs and symptoms that cause anemia. But on top of that, you might have some yellowing of your skin, some jaundice, because all these cells that are, bilirubin lives inside a red blood cell as well. So if the cells bust open and the bilirubin gets to be free flowing out in your bloodstream, it can turn your skin yellow, like if it's too much for your liver to keep up with clearing out. It will make you, if you have anemia, hopefully your compensatory mechanism is going to work, and you're going to start to make more red blood cells, which is what erythropoiesis is. random question coming up after the slide. I don't know. Gosh, clearly got it in the wrong place. But we're going to talk about sickle cell and we're going to talk about thalassemia. And this is just one where there's a definition, like we might ask you, you know, the blood in the patient's sputum, how do you document it? Yeah. Okay, so sickle cell anemia. Sickle cell anemia is a terrible disease, and I really like to talk about it. Like DS seems terrible, but I like to talk about it too. And sickle cell anemia, y'all can see those pictures. See the ones that look like a jelly-filled donut that's a little bit compressed in the middle? That's what a normal red blood cell should look like. So those red blood cells, they look like that. They'll just bump off of each other and keep going. But you can see the ones that look like crescent moons, right? That look like C's. And so you can see if you've got a bunch of C's floating around in your bloodstream, they're going to stick together, right? And then another one's going to stick here, and one's going to stick there. So you end up with these clumps of red blood cells that stick together, and then they go and they plug up blood vessels. And it's where they plug up those blood vessels that causes the problem for a person who has sickle cell anemia. Things that can make them, the big things you need to remember are the first two, low oxygen and low vascular volume. So if a person who has sickle cell anemia is exposed to low oxygen levels for any reason, or they get dehydrated for any reason, it typically will set off a sickle cell crisis. So these individuals have this hemoglobin S that sickles under those conditions. So if a person that has sickle cell anemia, that hemoglobin might not be sickled up all the time, or it might just be a few cells that are sickled up. So they're not in pain and not having problems all the time. But unfortunately, folks who have sickle cell anemia sometimes have multiple sickle cell crises. And those crises are what will bring them to the hospital. So I was telling you that those cells clump up and then they go and they plug up blood vessels. Well, wherever they plug up a blood vessel, it's going to kill part of that tissue, right? It's going to block off the blood flow. So it's common that folks that have sickle cell anemia will get ulcers like you see down there on that foot and the leg down there. It's common that they get it in their chest, in their lungs. It causes acute chest syndrome. So those blood vessels in their chest can fill up. It's can get blocked, and then there's no oxygen being exchanged. It's very common that folks that have sickle cell anemia get those blood clots in their hip joint. So it's common that folks that have sickle cell anemia may have to have hips replaced because of death of the tissue from the clump cells blocking the blood flow. It can happen in any organ. So your signs and symptoms are going to be all these things. It's understandable why they have a large spleen, right? The sickled abnormal cells, they've got to be cleared out. Cells that bust open, and this is a hemolytic anemia, are going to lead to that bilirubin in your bloodstream. We've already talked about the blood cells sticking together. We've talked about the tissue death. Necrosis is tissue death. So anywhere that tissue is deprived of blood, it's going to die. Anything that, so I usually tell this story. We had this one time, somehow or other, we ended up with a hot dog. We had a church pew, church pew on our porch, and it has little plastic things for you to put your books in at church. Somehow we ended up with a hot dog in a Ziploc bag there, and we left, and it was a summer house, and we came back 2 or 3 weeks later. I was like, "What is that smell? My word, what is it?" Well, it was that rotten hot dog. So, but if you think about it, if you have your tissues not supplied blood, basically you have a rotten hot dog, right? It's meat, and your body's 98 degrees, so if you have dead meat that's sitting in 98 degrees, what do you think is going to happen to that over a few days? It's going to turn into what was in that little Ziploc bag with that hot dog. And so these infarcts very easily get infected, and infection is probably the #1 cause of death in a person that has sickle cell. I mean, if I have if the blood flow is cut off to my foot and that wound gets infected, and it's going to because it's dead tissue, to make matters worse, because the blood flow's plugged off there, it's hard for me to even get antibiotics there, right? Because the vessel that we bring the antibiotic there is plugged up, so it's a very, very hard thing to fight. We talked about acute chest syndrome a little bit. Y'all know what priapism is? It's an erection that doesn't go away. It's a painful erection that lasts for more than 4 hours for purposes other than sexual pleasure. It's all, you know, those Viagra and Cialis commercials that you see, all that stuff. They say really quick at the end of the thing, go to the hospital if that happens. That's what priapism is. Priapism is, not ism. Ischemia of the eyes. We've already talked about infections and that it being the big cause of mortality. So for a person that has sickle cell, probably the two most important things are avoid the triggers, right? So if you know that smoking is going to trigger a sickle cell crisis, don't smoke. You know, if you're going hiking, make sure that you take plenty of fluid so you don't get dehydrated. Then we want to give the patient some fetal hemoglobin. They'll get transfusions. Fetal hemoglobin doesn't sickle. So the idea is that if you can get hydroxyurea, which helps you make fetal hemoglobin, if you can get their fetal hemoglobin levels up, they will have fewer cells that can sickle. Right? If you only have two cells in your body that can sickle, then you're not going to have a big plug there. So the idea is to try and get the amount of hemoglobin that can sickle down as low as it can go. And then we've already talked about oxygenation and hydration. And if they are having a crisis, they're probably going to get some antibiotics just to hopefully keep anything that is dying off from getting infected. Thalassemia is another hemolytic anemia. Sickle cell anemia, I see I have here, this is autosomal recessive, so is sickle cell. And we'll talk about genetics in a minute, so you'll know what that means. Thalassemia happens most often in folks of Mediterranean descent, is the highest the population that it happens the most in, followed by folks who have Asian or African American descent. There is an abnormal hemoglobin, and it produces something called a Heinz body. And so the hemoglobin doesn't function very well, and they are hypercoagulable. So folks may have some growth retardation. But it's going to be there present from birth, just like sickle cell will be. So it may lead to growth retardation. They end up with these big old cheeks here, so they call them chipmunk cheeks. They get these bony abnormalities, and then they can have large stones, large livers, that kind of thing. So you want to try to prevent it as best you can. Give them antibiotics when they need it. They may need transfusions, just like the person who has sickle cell. Acquired hemolytic anemia means it's not something that you are genetically programmed to have, but you got it because of something else. It's very common to have it in blood transfusions. As a student, y'all will never give blood. And it's because these hemolytic reactions can be fatal, within just a few minutes. And so the school doesn't want to assume the responsibility of you being sent down to a room to be in charge of a person who's getting blood, and that happens and you don't recognize it and they die. So blood transfusions are super. It's not a good blood match. That's a really, really common reason for folks to have a hemolytic anemia. And then there are some drugs that can cause hemolytic anemia. That's what happens when you get a snake bite that kills people. So you can read through all those things. But blood transfusions and drugs are probably the most common causes. Anemias of deficient red blood cell production. That's what all the rest of these anemias are. So there are lots of nutrients, lots of vitamins that go into making red blood cells, and so depending on which one you're missing, it's going to help determine, it's going to, identify the anemia for you. So we could be lacking in iron, we could be lacking in B12, we could be lacking in folate. We're going to talk about all these anemias. We talked about iron deficiency and anemia a little bit early on, but it is just what it says it is. You're deficient in iron. And so because you're deficient in iron, you're going to make fewer red blood cells. They're going to be small in color, and they're going to be light in color and small in size. It happens in folks during growth spurts, It happens in women when they're pregnant because they're increasing their blood supply so fast that they don't necessarily have make enough. Don't have enough iron to make enough hemoglobin. That's why all pregnant women take a vitamin that has iron in it, because you need that for that growth spurt. And kids who drink cow's milk instead of breast milk or formula, they get anemia. People who don't have meat in their diet are more likely to have anemia the older you get. And then clearly, if you have some kind of GI disorder where you can't absorb food from your gut, then you're more likely to get an anemia of iron deficiency. When you start looking at these signs and symptoms, there's not that many that are going to be that different. There's a couple with that B12 and folic acid deficiency that we'll talk about, but most of these you see look like things we've already talked about, kind of. You know what a palpitation is? A palpitation is you feel like your heart pumping. Your heart, it just, I don't know, it just feels your heart's pounding in your chest. That's what that is. Angina, chest pain, brittle hair, brittle nails, I guess not being oxygenated well. We've already said all anemia should have an increased heart rate, pallor, they're pale. So, pica, do you know what pica is? Pica is the desire to eat something that's, not good. So, in the South, so women typically have anemia more often than men. And women who have anemia sometimes want to eat red clay. And children want to eat paint chips whenever they have anemia. A lot of people will crunch ice a lot. There's a craving for when folks have anemia. And then there's megaloblastic anemia, which means it's going to be a big, immature red blood cell. And these are all the things that can cause megaloblastic anemia. B12 deficiency, age, drugs, alcohol, lots of things. So the thing that we are concerned mostly about is that lack of B12 in pregnant women, which is folic acid, folate. And in women that have this when they're pregnant, their children often are born with a spina bifida. Do y'all know what spina bifida is? It's an open neural tube. It means that the bones didn't close well around the spinal cord, and so the nerves don't come out in a ordered way. And so they're all kind of jumbled up to where they come off of the spinal cord, and the children are usually crippled. Pernicious anemia is another kind of megaloblastic anemia, and in pernicious anemia, the worst thing about that is you lack this intrinsic factor, the one you see down here, that fourth bullet there. So it occurs in alcoholics, number one, pregnant women, people who don't eat, people who don't have intrinsic factor. Achlorhydria means you don't have any acid in your stomach. And then again, in folks who don't consume meat in their diet. With pernicious, let me go 2 slides. With pernicious anemia, you have a lack of folic acid or B12. And that's super important for your neurological development. So people who don't have folic acid and B12, they become neurologically impaired. So I'm sure you all have at some point in time in your life watched a movie where there's an alcoholic and they're talking out of their head and they don't make sense and they're kooky. And that this is the reason, because they've been deficient in B12 and folic acid until they have neurological degeneration. Yes, sir?
What did you say megaloblastic?
Big, immature. Blastic means like the baby version of a cell is not quite developed, and mega means big. So big, immature cells. Big, immature red blood cells. So that's the thing that you worry about in folks that have pernicious anemia, is that they're going to end up with neurological changes. If you can correct the anemia before they start to have the CNS degradation, then it will rebound. But if they are already starting to have these like hallucinations and they're confused and that kind of stuff, a lot of times you can't come back from that. So it is the signs and symptoms of all these anemias are going to be similar to what they are for any anemia, except that with pernicious anemia, we're gonna tell you something about them neurologically. They're confused, they're stumbling, they're slurring their words, something like that, so that we include you in that they're having neurological problems along with their other signs of anemia. And aplastic anemia is probably it's the worst of the anemias that you can have. I believe it's the last ones in this lecture, but aplastic means without growth. So this means you don't have any blood cells at all. Like you quit making reds, whites, and platelets. And so without reds, whites, and platelets, you're gonna have all kinds of problems, right? The most common cause that I've ever seen of aplastic anemia has been drugs. Not street drugs necessarily, but medicines that are used to treat people. Whenever you read a drug label and there's all kinds of side effects that can happen, it doesn't mean that every person that takes that drug is going to get that side effect. It means some people will. It has been reported. Some people have had this. So a drug that causes aplastic anemia may not be used. So it's not like we can just say don't use that drug because people have different reactions. And then toxins like snake venoms can cause it as well. And so they're going to have a sudden onset of everything. Infections, bleeding, fatigue, all of those words that we've already been talking about. And then the treatment is going to be, if you can get rid of the cause, get rid of the cause. They're going to get transfusions. And then they may have to get a bone marrow transplant if it's something that doesn't correct itself. Usually, if it's a drug or a venom or something like that, it will, the blood will rebound and start being produced once the problem goes away. How y'all feeling about that? Somebody asked me a question. I wanted to be sure to tell y'all. What was that? Can't remember what it was. It was something I wanted to tell y'all. Somebody came at the end of the break and they had on a green sweatshirt, like sparkling. Oh well, maybe it'll come to me. Well, y'all take a break again and I'll pull up the genetic PowerPoint. Micro means little, so it's a small head. And macroorganism means large testicles. Microcephaly is small head, macroorganism is large testicles. A lot of you girls are thinking that describes your last boyfriend in a nutshell. So we're going to talk just a minute about the Human Genome Project. What the Human Genome Project is it was a long study that was carried out across about 20 years by scientists, people who are certainly more intelligent than I am, and they looked at mapping out the whole genome of a person. And from that, they have found links to many diseases, and it's also opened the door for us to know which kinds of medicines work good for which people, right? There's genetic testing that can be done. Say, for example, you have high blood pressure. And, you've been tried on 2 or 3 blood pressure medicines, and it's just not working. So there is actually genetic testing that can be done to determine, what class of drugs would be the best to treat you for high blood pressure or gout or, various different disorders. So that's what came from the Human Genome Project. So we're going to talk we're not going to do a whole bunch of genetic review, but we're going to talk just a little bit about it just so that y'all get really familiar with what all the parts are. So y'all know what DNA is. DNA is made up of your genes. So your genes is what carries the genetic information. So that's where all your genetic information lives, is on that DNA ladder that we showed in the cancer lecture. And your genes carry all the directions for everything about you, how everything's made. Your DNA lives in the nucleus of the cell. Every cell has the full amount of DNA that you have. So, if I was smart enough, I won't say you're not, but if I was smart enough, I could pull a piece of one of your skin cells and I could take it to a lab and I could grow your heart or your lung or your kidneys, because every bit of that information is in every single cell. It's just that some cells, when we're talking about expressivity, they are more pronounced in groups like that, and so that's why you have a bunch of cells that act like a liver, a bunch of cells that act like a heart, and that act like a kidney. Y'all know that DNA ladder duplicates, and then it splits, right? And it, we already said it looks like a twisted ladder. We already said that it has that, if it's unrepaired, it can lead to damage. That split occurs in the cells, I'm getting a little bit ahead of myself, but in the cells that are not the 23rd pair that determines your gender, they split and you have a full genetic information from both. And that in the 23rd pair that determines your gender, you only get half of that genetic information. The RNA, it really provides directions and provides nutrients and needed pieces and the place and the machinery for the DNA to be repaired. It doesn't really carry any genetic information. It really carries instructions. Okay, so we already said this before. The genetics are the same in every cell that you have. We already said they're not all expressed the same. If you're going to have a mutation, it's typically going to happen during the time that ladder splits and it reforms. That's usually when the mutation happens. And then, depending on how much material is lost, it's going to determine the severity of the disorder that it presents. So if you lose a little bit of genetic information, you're probably going to have, not much of an abnormality. If you lose a lot, say for example, maybe the gene that carries some part of your psyche, you lose a little bit, you might have a little bit of autism, you might be a little shy, versus you might be completely, non-functional. Does that make sense? It depends upon the amount of genetic information that you lose. And then where you have lots of genes that live together, they form chromosomes. Y'all remember the business about the 23 pairs. It's that 23rd pair that's going to determine your gender. The other 22 pair are called autosomes. So when we say autosomal dominant, we're saying that it's not carried on that X chromosome. It's not in that 23rd pair. We said that you get happy that the ladder splits, and in that 23rd pair, you're going to have some genetic information from dad and genetic information from mom. This is a karyotype, just as an FYI. It's a picture of what your chromosomes should look like. So it's that 23rd pair that determines your gender. Females are 2 X's and males are an X and a Y. So females, because they carry 2 X's, are less likely to be impacted by an X-linked disorder. I'm trying to look and see what I've got coming up. I tend to find myself getting really ahead of myself in these talks. I'll just go ahead and say it. So if you have, let's say baldness, for example. Baldness is an X-linked recessive disorder. So if a female gets a X that's got a gene for baldness on it, because she also is likely to have an X that doesn't have baldness on it from either or the parents, the female's not as likely to become bald, right? Now, if a male gets a bad X from the mama, he's probably going to be bald because he doesn't have any more X content to try and balance that out. Does that make sense? So that's why X-linked disorders are way more common to males than females. It can happen in females if it's a real strong gene, or maybe the girl will get both, get 2 of the same bad genes, one from mom and one from dad. But anyway, that's why it happens mostly in guys, not girls. So this is what I was telling you about before on a couple of occasions where you have mitosis is the autosomes that split and you end up with full genetic information in each cell that breaks off. And then meiosis is what happens in the sperm and the ovum, so that it's carrying half of the genetic information so that when they come together you end up with a full set. We said the first thing already. We've already said the second thing. We said that. Gene mutations in somatic cells, that means the 22 pair of autosomes create diseases or disorders, and if it's in that, the gametes, then you're gonna end up with, diseases passed to the offspring, so that the parent having them. Recombinant DNA technology, what that is, it's something that was learned partially through that Human Genome Project, but, scientists learn how to, split DNA, insert materials into that DNA, and then have it replicate. So a lot of our drugs are made that way. For example, 40 years ago, insulin, if you needed to take insulin, it was harvested from like pig and cow, I said insulin, pancreases. But now we know how to take insulin, take the DNA from the insulin, put it into a virus or a bacteria, and that virus or bacteria makes all this insulin, and then it's purified and extracted, and so it can become a drug. So that's what recombinant DNA technology is. Okay, so genetic versus congenital. Genetic means that it was in your genetic makeup, and congenital just means it was there when you were born. Does that make sense? So, things happen to babies it's not determined by their genetics. Like, for example, we were talking about spina bifida. Spina bifida, with that open neural tube, would be a congenital problem, right? The mom didn't get enough vitamin B12 in them when they were pregnant, and so the baby has spina bifida, or that open neural tube. It wasn't genetically programmed. Like, they didn't get a gene from mom and a gene from dad to say, you're going to have an open neural tube. Does that make sense? Okay. So congenital just happens. Genetics is pre-programmed into you. Do y'all remember how to do the Punnett square? Okay. So, because there'll be at least one question on the test that says, mom has this genetic makeup, dad has this, what's the likelihood that their offspring, a child would be a carrier, have a disease, or would be completely unimpacted? So we'll ask that. If you don't, you might want to go back and refresh, but it's pretty basic, I think. You probably remember it from high school even.
So for that, are we gonna get scratch paper?
Yeah, we'll have a scratch paper.
Okay.
We don't give scratch paper in every exam, but we give them for some of them. Yeah, maybe I'll even draw a Punnett square on it for you. I'm gonna figure it out. That'd be good. Okay. So penetrance and expressivity is the thing that I was kind of alluding to before. That penetrance says that how likely is it that you are going to look like how likely is it that you're going to have a disorder? And then expressivity is how bad will it be? So let's say genetically, I'm trying to think of it, maybe it's sickle cell. So how likely is it that you're going to have sickle cell anemia? Then expressivity says, well, how bad is your sickle cell going to be if you do have it? Are you going to be a person who has a crisis once a week, or are you going to have no crises in your lifetime? So penetrance means how likely are you that you're going to have it, even if it's in your genotype. Are you really going to get it or not? And then expressivity means how bad is it going to be if you do get it. And this is where I should have stopped my mouth from before. This is all that business about the X-linked disorders. So I don't think I'm going to say that again. And this is the Punnett square for an X-linked disorder. So the first, we're going to now just talk about some different genetic disorders. Some of them are common, some of them are not so common. We're going to talk first about autosomal dominant. So if it's autosomal dominant, how many genes do you have to get the disorder? 1. On that Punnett square, it's usually represented as a capital letter. And you only have to have one of them to have the disorder. So there are some inheritance patterns there. Marfan syndrome is the first thing we're going to talk about, and that may be the only dominant. No, we're talking about another one. Is an autosomal dominant disorder that we're going to talk about. Marfan syndrome is a disease of soft tissue and skeletal tissues. So folks that have it are going to have exaggerated skeletons. They're going to be very long, long legs, long arms, crowded teeth, and they're going to have maybe have ocular problems, vision problems. But the biggest problem with a person that has Marfan syndrome is that thing down there near the bottom that talks about cardiac abnormalities. It's common for folks who have Marfan syndrome to develop aortic aneurysms. Y'all know what an aortic aneurysm is? It's when your aorta weakens and balloons out, and then it can rupture. So that's the thing that we worry about so much in folks that have Marfan syndrome. So this is a picture, a couple of pictures. So you can see how this boy over there, how tall he looks and how long his little arms and legs are in comparison to his torso. And then what you see there, that pectus excavatum, that's a common finding in folks who have Marfan syndrome, and it looks like if your chest is made of Play-Doh, somebody took their fist and pushed it in. So depending on how deep that is, it may need to be corrected or it may not. Typically, if it has to be corrected, it's corrected more like up in the teenage years, and they're only really going to try and correct it if it impairs your heart or your lungs' ability to work. As long as those organs work well in your chest cavity, they're not fixing to, open your chest and reconstruct it. So we think Michael Phelps has Marfan syndrome. I think. So in researching it, he meets physically he meets the criteria. He's got these super long arms. He's double jointed. He has crowded teeth, and he says that he sees his cardiologist regularly. Well, if you think about Michael Phelps, now maybe not today because he's not still swimming like he was, but at the height of his career, would you think he didn't probably have the best heart of everybody in the whole world? So you have to think, why would somebody that's in that good shape be seeing a cardiologist all the time? So that's my deduction. I think it's got Marfan syndrome. Huntington's disease, it used to be called Huntington's chorea, is another autosomal dominant disorder. So again, you only have to get one bad gene. Did any of y'all watch Virgin River? Any of y'all watch that show? That's what that little boy has. That the young heartthrob right now. He has Huntington's chorea. So what happens is you're born normal, and then time you get to be about 30 years old, 40 years old, you start having this neurological decline, so you start having this spastic arm and leg jerky movement. It's how it kind of begins, and then you die. So there's not a treatment for it, and if you have it, chances are you're going to die by the time you're about 50. So spastic arm and leg movement, progression to neurological death. And so here's, so the next is we're going to talk about autosomal recessive, and we're only going to talk about PKU, the first two, PKU, phenylketonuria, and Tay-Sachs disease. Phenylketonuria, what happens in phenylketonuria is you're missing an enzyme. Enzyme's in the word, in the letters ASC, by the way, but you're missing an enzyme that breaks down phenylalanine. So phenylalanine is found in foods that have high protein content, and if you can't get phenylalanine out of your bloodstream, it degrades your brain. So children that have PKU will be born normal, they'll have normal mentation, and over the course of their lifetime, they will have neurological decline if they don't eat a phenylalanine-free diet. So they will, they won't be retarded or mentally handicapped when they're little, but the older they get, the more so they become that way. If a person does have PKU, if they eat a phenylalanine-free diet, then they're not going to develop a neurological decline. So back to stories of having babies. Any baby that's born in the United States in any kind of health care or goes to see a health care provider is going to have a PKU drawn. And that's what they want to find out, does the baby have PKU or not. It's not terribly uncommon, and the outcome is so poor that there's no reason not to. So the baby has to have had something to eat. They have to a non-sterile gut, and when you have your babies in the hospital, they'll draw the blood the morning before you leave to go home. And if you had the baby at home or you had the baby outside of a healthcare place, whenever you do take the baby in, they're going to check for that. And so then you just have to eat a phenylalanine-free diet, which means it's going to be a low-protein diet. We have a couple friends who have children that have PKU in their house. Tay-Sachs disease is a much more severe kind of disease, and here you're also missing an enzyme, but this enzyme breaks down fat. And if you can't break down fat, it tends to accumulate. It tends to accumulate in your brain really badly. So essentially, these children are born, and their brain gets converted to fat. And so you can imagine that fat's not going to function the way brain tissue should. So these children, again, well, that happens most often in Jewish people of Mediterranean, from the Mediterranean area. That's the population that's at highest risk. And so once again, these children are going to be born and they're going to look just perfectly normal, and they're going to do okay, but the parents are going to start to notice that the baby's not meeting the neurological milestones like they should. So any of you that have had children, you know, there comes a time when you think your baby ought to start following you around the room and be able to hold their bottle and be able to lift their head and that kind of stuff. So the parents will begin to notice that the baby's not meeting those milestones probably and say, hey, you know, what's up with this? And the baby's going to rapidly decline, and they usually die by the time they're about 3 or 4 years old. And again, there's not anything you can do about it. They get this classic cherry red spot on their eye. That's a diagnostic thing. And then clearly they can do the genetic testing. You know, there'd be a history to find out what their ancestry is, a genetic workup, especially if they have that cherry red spot on their eye. But it's really sad. They will, you know, go from being normal to just having steady neurological decline. X-linked disorders, we're only going to talk about Fragile X, and Fragile X is really what it sounds like. The X part of the X material is broken off on that 23rd pair of chromosomes, so you don't get all the X information that you need. So depending on how much you lose, it's going to determine the severity of the deficiency that you have. So it could be very almost not noticeable to very pronounced. They tend to have large testicles, long faces, everted ears, hyperextensible joints. And this just shows you how part of the X material broke off. Chromosomal disorders means that most likely you had abnormal numbers of chromosomes. You can have abnormalities in the chromosomes, but most of the time it's going to be an abnormal number, and that usually occurs during the time of the split. So maybe they split and you end up with two X's from mom and one Y from dad, or you might end up with just a single Y or just a single X. And most of these babies don't survive. Most of them, you know, they're miscarried, but some do survive. The most common one, and there's a lot of survival with this, is Down syndrome or trisomy 21. So that means on that 23rd pair of chromosomes, you got 3. You got an extra set of information. These children typically have, I mean, probably you all know someone who has trisomies, or you've seen it on TV and that kind of stuff, so you have an idea about what these individuals look like, but they typically don't mature neurologically. They have lower set ears. So if you took a ruler and put it from the top of your ear to your eye, it should line up. But in a child that has Down syndrome, the ears are going to be lower. They have a little bit of a slant to their eyes. They tend to kind of keep their mouth open a little bit and let their tongue kind of sit a little bit. Children who have trisomy 21 are more at risk for developing Alzheimer's than folks who don't. So I have some pictures of individual children with Down syndrome. Super sweet, super cute. Okay, Turner syndrome means you only got one X. So it's a girl that only either got an X from mom or dad, you know, didn't get both. Some children that have Turner syndrome will survive. A lot of children that have Turner syndrome, they're never born. The mom will have a miscarriage at some point in time. But if they are born, they're going to be female. They're going to have, they're not going to have, they're going to be sterile, right? Their ovaries and their breasts and that kind of stuff are not going to develop. They're going to be short. They're going to have a coarctation of the aorta is the worst thing and all that. And it means that the aorta's kind of clamped down, so it's gonna cause all kinds of cardiac issues. So short stature, web neck, cardiac abnormalities. Then Klinefelter syndrome means that there's a third X. There's too many X's. So if it were to happen in a female, it wouldn't be that big a deal because, you know, you can't really be more female than female, right? If it happens in a male, males are going to be a little more effeminate because they got extra female genetic information. So these males that have Klinefelters will have maybe like gynecomastia, breast development. Maybe they wouldn't have much hair on their face or their chest. Their voices might not deepen up during the change, you know, when you, not the change of life, in puberty as the boys' voices typically get deeper. So they're going to have more female secondary sex characteristics than what your average guy would have. Their testicles may not develop as they should. So they may or may not have sterility. And then multifactorial inheritance, it just means that you may inherit a genetic predisposition to have something, to have a disease. But it doesn't mean you're necessarily going to get it, but then lo and behold, you might be exposed to something in the environment and you end up with that disorder. And so that it's multifactorial. You're at a higher risk, and then something happens. And we don't know what that something is. The thought is a lot of times that it's some kind of viral exposure to something viral that will trigger the onset of these disorders, autoimmune disorders especially. So I guess about 15 years from now or so, we'll see if how much that happened with COVID, right? Because lots of us got exposed to viruses that, in large numbers, that probably hadn't before. Some diseases that are thought to be multifactorially inherited are listed there for you: diabetes, hypertension, heart disease, schizophrenia, several. This slide's in here just to let you know that when a baby is in utero, so when it's a fetus, all the organ systems and all the organs form within the first 60 days post-conception. So anything that happens environmentally, alcohol, any drugs, if you're taking any kind of medicine, oxygen deprivation, anything like that, it's going to have the biggest impact during those times. Because let's say that you are taking a medicine that has effects on a baby when the baby's brain is developing, and you prevent the baby's brain from developing, it's going to be much worse than the baby's brain is already developed, and it might just not get as big, right? And that can catch up after they're born. So that first 60 days is the most crucial period of time. I have a little nephew that has a friend, and they have a little boy that's, I think he's about 3 or 4 years old, and she drank, the whole time she was pregnant, and well, in the first 3 months, and I remember saying, that's really not good. She said, I'm not that pregnant, I'm just a little bit pregnant. I'll quit when I get to be more months. Well, the baby has a seizure disorder. It's like, we tried to tell you. So anyway, I'm sure that's what happened. And then the last thing we're going to talk about is how do you go about diagnosing things in babies before they're born. So depending on what you think might be, what abnormality the baby might have is going to determine the kind of exam that the baby's going to need. So y'all all know what an ultrasound is, right? An ultrasound shows you structure. So if you thought, maybe the daddy only had one kidney, so you want to know if the baby's got one kidney or two, you would do an ultrasound. All babies get is it about 21 weeks or so, they do that full body scan to make sure that the baby's got all the organs that they're supposed to have. That's what you're looking for there. An alpha fetal protein is a blood test to see if they have an open neural tube, that spina bifida that we've talked about a couple times today. Or it could be that their stomach is not, it doesn't have skin closing it. If you suspect that, if the mom, was vegetarian, didn't take their vitamins, didn't gain any weight, that kind of thing, that would be the baby who would be at risk for developing spina bifida. Then an amniocentesis is where, not what an amniocentesis is, they stick a needle in and they pull out amniotic fluid. You can find genetic and chromosomal defects there. And then chorionic villus sample, that really is a biopsy of the placenta. And so you can see if there's any genetic disorders there. And you can also do that by drawing blood from the baby, from the mom. How are y'all feeling? So look, somebody asked me during the break, do we have questions where they have lots of right answers, but we think one's more right or better than the other? We don't. So again, back to that, read the question, think about what you know about, and then go answer your question. And it will keep you from picking wrong answers. What you will see is, like I might, be asking a question about what do you expect to find in a person that has something. And I might have a sign or something that comes from Tay-Sachs, and one that comes from PKU, and one that comes from Down syndrome. And so it's going to be hard, unless you really own the content, you're going to think, oh, yeah, I remember reading that. I remember seeing that, and you're going to have a tendency to pick it. So you really have to own this content. You can't just read it to get familiar with it. You're going to have to own it, because what you all think is tricky, I mean we're not going to say what disease do they have.